practical pediatric endocrinology course is actually something which has been quite close to Grow Society, and we've been doing that for quite some time. We actually started off initially with the programs which were there in terms of the initial workshops, which started way back in 2010. We conducted around workshops across the country. In 2011, we had the first practical pediatric endocrine course, and Dr. Raghupati, Dr. Chaurasia, and Dr. Rashmi Kapoor, all three of them were part of that inaugural program as well. Subsequent to that, we realized that doing programs at the level of individual places, we started doing PPECs across the country, was very labor intense and was very difficult to manage, and a lot of logistic issues. So we thought of using the social media, the YouTube and the Facebook platform to spread knowledge about pediatric endocrinology. And from there, we realized that while videos are going to help out, we need something more concrete in terms of more information which is available. We started with the round fellowship programs, but how many fellows can you accommodate? 2 or 4 in a given time. If you want more people to learn, the best way was to go online. And in 2018, 3 years ago exactly, on this very date, we started MedEClasses, which is a learning platform, and this is really evolved now with multiple other factors happening in the form of books and mobile application to make it much easy in terms of overall aspects. So over the last 11 years or so, we have conducted multiple programs across the country. Over 10 PPECs have been conducted. There have been over approximately 8 modules which have been involved and implemented in around 100 workshops across the country. So a lot of people have interacted and really find friends across the country in that regard, which has been really helpful in that perspective. So as discussed, we started off with our online learning program. And this e-learning started off with the number of videos which are now available on the YouTube. And on last count, there have been 700,000 views from those videos, watch time of around 40,000 hours. So there's a huge amount of pediatric endocrine repository which is available, which is being accessed across the world. But as I discussed, that this is more like a non-systematic way. We therefore went ahead and started with our learning.growsociety.in to provide pediatric endocrine learning using validated tools and practical assessment. And we have got multiple courses. Till now, we are on 24 courses available. We've got special courses for postgraduates and fellows, providing specific needs using animated videos, lectures, and other information. We also conduct bi-weekly grand rounds. So every month we have got one for the postgraduates and one for the fellows. So it's free over Zoom. All of us should join. We already have around 700 people who are regular join these programs. And this is quite helpful from that perspective. As Sir was talking about, we had this basic pediatric endocrinology, and just recently, 3 months ago, we launched our advanced pediatric endocrinology, which is a 2-volume book related to every aspect of pediatric endocrinology. So entire course content is in these 1,000 pages, which are there in these 3 books. So these 1,000 pages, they're all online, as well as now we already made it offline as well, available for people. We always realize that the best way to practice is not really going through books, but to actually go from patient to the book and back. And therefore, we started developing these applications which make life much easier. So rather than going back and reading about DSD, you start off from the patient's point and then use that application approach pathway. So now the endocrinology app is by far the most resourceful endocrinology app on the web and the most downloaded one as well. It has got over 50 pathways, management, approach pathways, analytic tools. And over the next month, we're going to make a massive change in that, adding many new interpreters like puberty, DSD. So if you just put 4 inputs, you will get an output of DSD, output for puberty and obesity. I'm in pediatric endocrinology. This is a complete 3-year program, which is actually a hybrid program of both on-site and online over 4 weeks of visit, as well as online, as well as a diploma course in pediatric endocrinology for people who have got lesser time. Calcium module today. And in that, we have got 4 faculty experts, Dr. Pradeep Kumar, who is working as Associate Professor at AIIMS Patna, Dr. Anamika Saha, who is from Bangladesh, Dhaka Medical College and Hospital. She's working as a consultant there. Dr. Chizam, who is very active in pediatric endocrinology from Nigeria, and Dr. Lalit from Balaji Hospital. I'll be joined by Dr. Prateek, our erstwhile fellow and now consultant in pediatric endocrinology at Regency CDER to discuss this session from there. So Dr. Pradeep needs no introduction for our group. He has been involved very closely with regards to MedEClasses and other aspects, and he's been doing very active job in terms of setting up a pediatric endocrine clinic at Patna. And welcome, Dr. Pradeep, to the program. Dr. Vijay Jaiswal, who is the head of department at Lala Lajpat Rai Medical College, Meerut. Dr. Jaiswal has been very closely associated with us right from the onset of practical pediatric endocrine course for the last 10 years. Very dynamic individual. He's done fellowship from Dr. Vaman Khadilkar's unit at Bharati Vidyapeeth. Dr. Prema, who is the head of department at Rajeshwari Medical College, Bangalore, again, very interested in pediatric endocrinology, particularly in diabetes. Dr. Vikas Mehrotra, a close friend, colleague, and he has also been involved, like Dr. Vijay, right from the offset with regards to the different aspects of Grow India, MedEClasses, and other aspects. And I'm really proud to have Dr. Hemang also as part of our team. Dr. Hemang was working here as an intensivist fellow, and he is the brain and a lot of other brain and brawn behind the MedEClasses DKA application, which is a wonderful application which really helps you do precise management of DKA. And we'll discuss how this came up and how it will go forward. I'll be joined by Dr. Naveen, our fellow, who will carry forward with regards to the cases. But before we go, we'll basically have a quick word about the basic pathophysiology of DKA. So we all know that DKA is predominantly because of two things. You have insulin deficiency and you have counter-regulatory excess. Now, both of this is important. Individuals who have a multiple pituitary hormone deficiency will basically have an issue with regards to not having DKA because they don't have a counter-regulatory excess. Insulin deficiency will cause increased lipolysis, producing ketones, ketogenesis, and this ketogenesis causes all the features: acidosis, rachypnea, abdominal pain, and rapid breathing. While the counter-regulatory excess along with insulin deficiency causes release of glucose, causing hyperglycemia, which then causes osmotic diuresis and massive loss of potassium, sodium, and water. So there is a huge deficit of sodium, potassium, and water in anybody who has diabetic ketoacidosis. And because your volume goes down, you will again have this counter-regulatory hormone going up. So this is like a vicious cycle carrying on, and this is something which will ultimately lead to death if you don't treat it appropriately. And of course, your RAS axis will go up, and once RAS axis goes up, your potassium will come down. That is, I think, something which is again going to be very contributory. Now, what does it do? In the setting of DKA, you have 7 to 10% dehydration, but the clinical assessment of dehydration is not very accurate. So be careful. Don't over or underestimate dehydration in DKA. Go one step lower. Sodium is always low, but you will tend to overestimate sodium deficit because there is pseudo hyponatremia. So for every 100 milligram per DL, your glucose goes up. You add 1.6 to your sodium, and that will be the corrected sodium. And corrected sodium is by far the most important parameter to follow in anybody who has diabetic ketoacidosis. Potassium again will be low, but you will underestimate the deficit of potassium because you have got insulin deficiency and acidosis. Potassium comes out of the cell. And again, in this setting, basically, once you start treatment, you will have severe hypokalemia. So if you mark my words, if you have a very, very low sodium at diagnosis, if you have got a low potassium at diagnosis, you have got something to worry about. This is not your day run-of-the-mill DKA case. There are some issues which are there, which you have to be careful in that perspective, and this is very important. One simple formula by which you can understand what potassium level is, that for every 0.1 decline in the pH, the potassium should go up by 0.6. So if your pH is 6.9, you should decrease potassium by 3 in your blood. So potassium of 5 will become 2. So this is a rough way of looking at how much metabolic acidosis can impact the potassium level in this perspective. Now, how do we treat? Of course, the first thing is fluid. Now, as soon as you give fluid, the volume comes down, the volume goes up. So there is dilution of the concentrated glucose and the counter-regulatory hormone goes down, and there would be a rapid decline in glucose by typically 100 to 200 milligram per DL. If you give insulin now, your glucose will rapidly fall, and that could be very, very dangerous. So do not give insulin in the first 1 hour. But after that, you need to give insulin, which will then decrease ketogenesis, and that will result in improvement in that perspective. But you need to be cautious. If you give too rapid correction, you can cause problems like cerebral edema. And if you give too much fluid, there could be a problem of hyperchloremic metabolic acidosis. And often we tend to treat hyperchloremic metabolic acidosis with insulin. Insulin is not the treatment for hyperchloremic acidosis, and this is what you need to understand. If you give too much insulin, you will cause hypokalemia and other problems. The major complications to watch out, of course, number one is cerebral edema, which usually occurs with severe disease, giving too much fluid and giving bicarbonate and osmotic shift. It is a bad condition. This is the major cause of death in DKA. Any child with DKA, altered sensorium, check sugar. If it is normal, think DKA, give mannitol. That's pretty much end of the story. Do not wait for imaging. Do not give too much fluid, give a slow correction, and that's how patient will improve. Hypokalemia is the second most dangerous thing, usually occurs with insulin, so give potassium. If your potassium is low at diagnosis, that is a serious issue to worry about in that perspective. And of course, if acidosis is persisting, think of other diagnoses like lactic acidosis and infection and hyperchloremic metabolic acidosis. Do not give soda bicarbonate unless the pH is less than 6.9, there is a cardiac arrest, or there is life-threatening hyperkalemia. Do not give it as a bolus, always give other infusion if you have these three conditions in that regards. Be wary of infections which may be there, thrombosis, so do not put central line. If you put central line, give low molecular weight heparin. Do not intubate, because if you intubate, there will be a CNS pressure which will go up. And very importantly, if there is a sudden shaking of the muscles, if there is a muscle pain, if there is hematuria, and this was part of the quiz also, think of rhabdomyolysis and your CPK levels will go up. You will have oligouria and renal failure is what is going to happen. Now we'll start off with the first case.
A 3-year-old boy was a known asthma patient and was admitted in the pediatric emergency department and was on steroids for a very long duration for around 1 year or more. And sort of routine ICU protocol is blood sugar was done, which was found to be high, and it was found to be 220 milligram per deciliter. And a part of respiratory distress is VBG was done, which showed acidosis with pH of 7.22 and bicarb of 18. So do we have hyperglycemia?
Thank you.
Yeah, hyperglycemia and acidosis. So do you think, is it really DKA, and what are the various features of necessary for diagnosing DKA, Dr. Vijay?
Thank you. This is really a very good case scenario, and it is very common in the diabetic patient. So since he is having steroid, blood sugar is hyperglycemia that is beyond 200. You can see here that pH is on acidotic range. So whether this is qualifying for DKA, so I should go more elaborate that DKA is a diagnosis of the triad. At least there should be three things. That is diabetes, it means that blood sugar should be beyond 200. Ketosis, that is ketones, either blood ketone is more than 3 millimole or that urinary ketone should be positive, and the pH should be acidotic. So all the three components are there or not, we have to see. So if we are going to collaborate this case, probably it is not so. Can you move further? Yes. So yes, please go back. Please go back. Yes. Yes. So whether this case was having two things, that is, one is acidosis and the second was that glucose was beyond 200. But acidosis and ketone body is what. So whether this is a sick day child, so we can't say that this is diabetic ketoacidosis. On the second case, what you are going to see here, that blood sugar is beyond 200 and acidosis is there or not. So depending upon that, if there is only high blood sugar, then probability of stress hyperglycemia will be quite high. So we should take the account of all the three parameters.
Yes, sir. And the ketone level was done, which was found to be on the lower side.
Yes. So you can see here. Yes. Yes. So since the child was on beta-2 agonist, so it is also going to add up some more blood sugar, and he was unwell. So it is not prudent to qualify for DKA, but yes, stress hyperglycemia was there, and this was due to a sick day. So basically, this child requires sick day management, and more frequent blood sugar monitoring should be required.
So thank you. And unfortunately, the patient developed type 1 on follow-up. So moving on to the next case, we have a 1-year-old boy who came with a complaint of failure to thrive since birth. And on exam investigation, he had a pH of 7.12 and a bicarb of 15 and anion gap was 20, which was showing as moderate to severe acidosis. And his ketone was found to be very high with 3.2 millimole per liter. And his blood sugars were fluctuating between 80 to 200 milligram per deciliter. So do you think this is a case of DKA, Dr. Prema?
Good afternoon, and I thank Dr. Anurag for giving me this wonderful opportunity to be here. And coming to the case, this is a 1-year-old boy, and the history shows there's a failure to thrive. And we have seen the ABG, which shows that a pH of 7.2, way less than 7.3, which shows its acidosis. First, we consider the pH in an ABG, then we see into whether it's a respiratory or metabolic. As a bicarbonate is 15, we know it's metabolic. And coming to anion gap, as it is more than 12, we know there's an anion gap acidosis in this child. And also the ketones are definitely more than 3, as you have shown the triad of diabetic ketoacidosis, where the ketones have to be more than 3. So we have fit in the things of acidosis and ketosis. Next, coming to the blood sugar to fulfill the other criteria of decay, that is hyperglycemia. Here you are telling the blood sugar is between 80 to 200, which I'm not really, we are not sure whether it is hyperglycemia or sometimes it is normoglycemia. So I would like to see if there is if whenever I'm unsure about this hyperglycemia, it is always better to do HbA1c. So what happened to the HbA1c in this case?
We got HbA1c done and it was 5.4.
5.4. Okay, so the HbA1c is 5.4. Definitely, it is not diabetes. So we are seeing here that the 2 components of the triad is fulfilled, that is ketosis and acidosis. So if we have only hyperglycemia and suppose and ketosis as the previous case, that fits into a stress-induced hyperglycemia. Here in this case, there is only ketosis and acidosis, which we should think of organic acidemias. So if you are thinking acidemias, especially in a neonate or an infant with then we have to go back to the history to find if it is autosomal recessive, whether there's history of consanguinity, any developmental delay or seizures. So any other history has to be taken for diagnosis of this organic acidemia. So in this case for a DKA, we have to be very sure that we should not start off with medication for DKA without completing the triad, because we would be unnecessarily putting the child with fluid and insulin, which is not the right treatment. So to come up with the
what are the messages, key messages in space from this case?
Yeah, the key messages from these 2 cases could be like, because this child, the first one had hyperglycemia and ketosis, we should always suspect an infection or a bronchial asthma in a child. And especially hyperglycemia, as we have seen nowadays with COVID, especially in young adults, who many of them have had hyperglycemia and stress-induced all these problems, and they later on also developed diabetes. So that and hyperglycemia, ketosis and acidosis, you should keep in mind of organic acidemia, and always do the blood ketones rather than urine ketones, as we know that beta hydroxybutyrate will be detected from blood ketones itself, and you should always be looking for stress hyperglycemia in these cases.
Thank you so much, ma'am, for the detailed explanation of how to rule out diabetes and the importance of starting insulin with a correct diagnosis of diabetes. So moving on to the next case, we have a 4-year-old girl who was actually managed out from outside in view of diarrhea. And at the time of admission, we had a pH of severe acidosis with pH of 6.8. Her bicarbonate was found to be very low of 4 millimole per liter. And she had a very high ketones of 7.1. On clinical examination, she was found to be drowsy and had anisocoria and reflexes were brisk. So what went wrong in the management of this case, Dr. Vikas?
Vikas, are you there?
Okay. Good. Thank you, Dr. Naveen. Am I audible now?
Yes, sir.
Hello. So, Dr. Naveen, thank you very much. And at the onset, I'm thankful to the entire team Grow India as well as Dr. Anurag Vajpayee to be the part of this extreme panelist. If you consider this case of a young child, 3 to 4 year of age girl, she has been managed as diarrhea. And if you see the pH and bicarb and ketones, we are dealing with a case of severe diabetic ketoacidosis, rather ketoacidosis. We cannot be sure about the diabetes. If you examine the child, she was drowsy and isochoria was there and reflexes are brisk. This is very, very important. Brisk reflexes in a child with ketones and severe acidosis. And considering the entire situation, we are dealing with a case of, can we have the previous slide, please? Just for 1 minute over. Considering the entire situation, there is a strong possibility of that this child of severe DKA already developed cellular edema, which is very, very, unwanted acute complication of diabetic ketoacidosis. It carries very high mortality and morbidity. Since she has been referred from a center and managed diarrhea, so it's very strong possibility of inappropriate, rapid, and inadequate fluid management. This might be the triggering factor for cerebral edema in this case. So whenever you have got a child of diabetic ketoacidosis, if she has got any of the reflexes brisk, or she is drowsy or anisocoria, or if you are having unstable hemodynamic parameters of the child, think of cerebral edema. And unfortunately, cerebral edema is present in most of the cases of DKA to start with. So don't waste time. Just rush for mannitol in a dose of around 0.5 gram per ml per kg, and it should be pushed as early as possible. There's no need of any imaging. But secondly, which is very, very important, is as we have already told by Dr. Vajpayee, fluid management is the mainstay of treatment of DKA. And so if we had a patient who has been referred from the outside, we have to go very slow. We have to undercorrect the dehydration and take care of the fluid which has already been given to a child. If you can find out from the parents how many bottles are there, try to reduce it, and should we go very slow and give mannitol. Next, plus.
So what are the key messages with regards to the treatment of cerebral edema?
So Dr. Naveen, whenever you receive a child in any of the ICU, PICU, and if you are suspecting cerebral edema, try to find out what the amount of fluid has to be given, and it has to be subtracted from the fluid which you are already given. You might be giving a less amount of fluid. It is okay with you, but you are not supposed to give extra fluid. You might not correct dehydration per se. You should go slow and under correction. Cerebral edema, always be alert. Any child who are doing otherwise well, sudden deterioration of clinical status, think of cerebral edema. No need of any imaging. Don't waste time of any imaging. Any localizing sign, think of cerebral edema. Any bradycardia with hypertension, think of cerebral edema. And always go slow and slow and slow. This should be the key message for anybody who is managing DKA. Thank you, Dr.
I think that's a very, very valid point mentioned by Dr. Vikas. The one key message coming out of here is that in India, if you have treatment outside, be wary about cerebral edema at diagnosis. Typically, we talk about 12 hours being the typical time, but we do see in our study, which Neha had done, we found that cerebral edema at diagnosis was very common in that regards. Yeah.
So thank you for
one last sentence.
Yes, sir.
You have to be very, very careful about cerebral edema because mortality is very, very high. It's almost 40%. And even if you are able to take the child out of PICU, you have got a lot of morbidity. So morbidity is also challenging, which might be the consequence of cerebral edema. So you have to be very, very careful as far as DKA and cerebral edema is concerned. Thank you, Dr. Vajpayee, for chance.
Thank you so much for the detailed explanation regarding the diagnosis and management of cerebral edema. And moving on to another complication with regards to DKA. We had a 3-year-old boy who was diagnosed as a case of severe DKA, and he was managed for a period of 6 hours. And after 6 hours, he got this investigation done, which showed severe acidosis with a pH of 6.9 and bicarbonate 5, and ketone was found to be high of 6.4. And when we got the potassium levels done, and it was found to be on the very lower side, which was 2.8 millimole per liter. So what do you think and what went wrong in this case, Dr. Hemant?
Dr. Hemang, are you there? Yeah, please unmute yourself.
Sir. Yes, sir. Sir, am I audible?
Yes.
Yes.
Yeah. So this is a case of severe decay, and now at the 6 hour of timing, he has a persistent acidosis, low bicarb, and persistent ketosis, and very low potassium level. So at this point of time, my main focus would be on this low potassium level. Potassium should be between should be more than 3.5 in any child in which we are giving insulin, because insulin pushes the potassium inside the cell, and hypokalemia is the second leading cause of death in a patient with DKA. So as such, as a part of treatment protocol, we should start potassium we should add 10 ml of the potassium in 500 ml of the pint in hydration phase only, and that will prevent the occurrence of the hypokalemia. So in this case, I should decrease the insulin, and I should recheck the potassium after 4 to 6 hours.
I think the big message again here that this child actually came to us referred at that point of time. So he has already been treated. So whenever they come, in most cases which come to us would have been treated outside. And often people miss potassium. If you miss potassium, you will have this situation. And that's why you have to be very careful in that regard.
So what are the key messages, Dr. Hema?
So as I told earlier, in DKA treatment, if we give insulin, it will cause intracellular shift of the potassium inside the cell. Second thing, resolution of the acidosis will also lead to shifting of the potassium inside. So potassium falls with the DKA treatment. So always start replacing potassium in even after 1 hour of the whenever you are giving hydration to the child, hydration phase. Okay. But one more thing, whenever we usually receive the patient outside receiving inappropriate fluids, so we should keep a watch on potassium level at the time of admission, because hypokalemia at diagnosis is a dangerous thing. And if you start insulin in this child, the child might have a serious hypokalemia and cardiac arrest. So we should start at 10 ml of the potassium in hydration phase, and we should.
Yeah, I think that's a very important message, Dr. Hemang. And the other question is that every time I talk about DKA, the pediatricians say, okay, why are you making it so complicated? Why we calculate potassium is this much, give that much. If your fluid is this much, give that much. So many calculations. We can't do that. We just follow a typical protocol. Can you improve the quality of care from there? How can you help on that?
Sir, as you say, sir, there are various protocols available, and we usually follow the IPPEC protocol. But this is the study done by me and my team with the guidance of Anurag Bajpai, sir, which says that only 18% of the patients we have managed correctly as per protocol, and in 5% of the cases we miss fluid boluses. In 12% of the cases we have given less or more fluid, and in 5% of the cases we have not started potassium in the hydration phase, and whenever glucose level will go down, there was a delay in addition of the dextrose. So ultimately this protocol deviation are quite common, and along with Dr. Anurag Bajpai, sir, we were thinking that how could we prevent this error. So this is the another chart which says that almost 42% of the hypokalemia can be prevented if we stick to the protocol. 68% of the clinically significant hypoglycemia can be prevented if we stick to the protocol. So these two are the deadly thing, and it is a preventable, and it is a huge number. So for this, we have came with a mobile application in which we have 3 different things. One is a just general guideline, what guideline says how to manage a DKA patient. That is a general protocol. Second is a diabetic ketoacidosis initial management part, and third is a diabetic ketoacidosis follow-up part. So if we feel weight, his potassium level, his blood gas, his sugar level, and his weight, it will give its interpretation like this, that this child has a DKA and we should follow this protocol. We should give 0.9% of the normal saline at this rate for 1 hour, and the hydration should be at this rate with we shouldn't forget adding potassium in a hydration fluid, and correct insulin dose for this patient would be this, and how should we monitor this patient. And in follow-up also, it will say hourly, it will ask for sugar, it will ask for electrolytes, it will ask for pH, it will ask for ketone, and give the inference that you should continue with the same fluid or change the fluid, increase the dextrose level, whether child is at risk of cerebral edema, and how to immediately manage cerebral edema using the mannitol, and what is the dose, and what are the another things which needs to be done in hypokalemia, decrease the insulin level, and close monitoring of the potassium, like this. So this application will help pediatrician to stick to a protocol, and by this way we can prevent almost 40% of the cases of hypokalemia and 60% of the cases of hypoglycemia.
That's a wonderful initiative which Dr. Hemang did. Yesterday we were talking about the bone age application and how a pediatrician can do a bone age in 2 minutes. And today we've got this DKA application, and this application is available as part of our MedEClasses app in both iOS and Android store. All you have to do is to put some inputs and you will get exact prescription. It's like your Dr. Hemang is always on call. You just put the data and he'll give you information what is to be done. And the wonderful part is that both of these are under publication in terms of the various journals. And the most important part is that both are the power couple who have done that. So one has made the bone age very easy, one has made the DKA very easy. So I think hats off to the great couple who have done this wonderful job. Thank you, Dr. Hemang, for that.
So moving on to another case where we come to the management part of DKA. A 10-year-old girl with a blood sugar of 540 milligram per deciliter and a base excess of 18 with a potassium of 5.8 and a pH of showing severe acidosis of 6.9 with dehydration of 10%. So how do you classify this patient and how do you manage Dr. Vijay?
Dr. Vijay?
Thank you, Naveen. So you can see the 3 parameters that this is the blood sugar is very high, that is 540, base excess is minus 18. So severe acidosis, pH you can see 6.9, and potassium is at borderline, that 5.8. So it can be tricky that at one point of time you are thinking that 5.5 potassium is a bit higher. But I want to say that previously we have already discussed that even in this case, after fluid resuscitation, we have to give potassium in the maintenance fluid, unless and until the patient is having deraised renal function test. So how to go about the case that first we have to, without any insulin, we have to do dilution method, that is normal saline fluid bolus 10 ml per kg. Then since this is a very severe disease, so we are going to manage in a very slow manner, that is about 48 hours. And we have to calculate the deficit to be fulfilled by 48 hours and the maintenance fluid by as SPAT protocols. And you can see here that 40, that is first 10 kg, 4 ml per kg, next 10 kg, 2 ml per kg, and the next that is 1 ml per kg. So maintenance fluid is coming to 70 ml per hour, and the deficit for every hourly maintenance is 65 ml per hour. So it is going to be 135 ml per hour. I'm not going to talk about the British Society of Pediatric Endocrinology guidelines or say NICE guideline, because the inclusion of the patient were not so severe patients. So I'm not going to discuss that. So first, that is, we have to give fluid therapy. And along this year, we have to take care of the precaution that our patient with can be.
Dr. Vijay, this is a very interesting aspect because we always talk about fluid, how much fluid to give, normal saline or N/2, a big debate. Now, in Western countries, especially in US, Nicole Glaser is a person who has done a lot of research on that. And they've come out with this study, which basically says whatever fluid you give, whatever rate you give, doesn't matter. It doesn't have an impact on cerebral edema. Do you agree that this is true for Indian setting as well?
No, definitely. I am not going to agree because you can see that, and I really thank to Anurag sir and his team that even if you are going to see that most of the cases are either in severe DKA or maybe at the time of presentation, they are already in cerebral edema. So that thing is not going to see. And if you are going to see the children, that how they are going to, so younger the age, they are more prone to develop cerebral edema. Newly diagnosed patient, depending upon the setting, probably 30 to 70% cases can present with DKA, and blood urea nitrogen, that is high blood urea nitrogen, are surrogative to indicate that this patient might be in DKA. And the last, you can see that hyperventilation, that is low carbon dioxide, can be indicative for potential danger for cerebral edema. So all these things has to be seen, not only the fluid, because our patient setting and the presentation is quite different from the Western world.
I think that's a big message that we cannot just blanketly follow the study, because if you look at the mean pH, here the mean pH was around 7.1. Our mean pH is around 6.9. That is the sort of thing. So in severe DKA, I would say still SPAT protocol is the best. Do not use N/2. You will have a rapid fall. Do not give too much fluid. That is not good. If you have a mildish DKA, you can manage in that protocol. It doesn't make a much difference. But remember, we have a high prevalence and a lot of people who got fluids outside. So you have to be cautious. That becomes relevant. So I would say outside treatment, pH less than 6.9, CO2 less than 10, think of cerebral edema very importantly in our setting.
Thank you so much, sir. And moving on to the next case. Now, how would you monitor this case, ma'am, Dr. Prema?
In all cases, we know we have made the diagnosis and we have started the treatment. And we all know that the complications of DKA are going to be, that is the one which is going to cause mortality. So monitoring becomes a very key part of our management. So if we just start the treatment and not monitor, we are going to land up in a lot of trouble. So the most important complication is, as we know, cerebral edema. So to monitor that, we have to keep an eye on the GC score. So we have to look into the sensorium of the patient, look and actually calculate the GC score every hour. So you have to see. And to look for cerebral edema, we have the early indicators, like you watch for the vitals. They could be increased in blood pressure, that is hypertension with bradycardia. So if you're seeing hypertension with bradycardia, you should be very alert about the cerebral edema. So that is one of the clinical signs. And the other clinical signs is, as I told you, the neurological signs. The neurological signs is you have to look in for the pupillary disturbances. You look for any cranial palsies or brisk refluxes, which also will suggest, or if the child is conscious, any headache, vomiting, those could even indicate signs of cerebral edema. So monitor early for neurological signs for cerebral edema. Then you look into the hydration status very early, so that you look like whether the child is hydration is okay. Look into the input-output chart, and also look for the urine output. It should be definitely more than 1 ml per kg per hour, because if there is a reduced amount of urine output, you have to look in terms of renal failure. Coming to the metabolites and electrolytes, very, very importantly, as we are correcting, we are giving a lot of fluids. We have to look into sodium and potassium. As we know, the next major killer is hypokalemia. So, and we know that the acidosis correction will be pushing the potassium into the cells. And as Dr. Anurag just told in the initial slides, that we have to give the correction for acidosis as 0.6 for every 0.1 reduction in the pH. So we have to be very, very careful about potassium. So you have to monitor serum potassium and sodium even secondarily initially. Then sodium, you have to, as already said, we have to look for the corrected sodium, and also if you're seeing the reduction in the corrected sodium, that should also alert about cerebral edema. So these are the important things. The last thing is the ketones. So we know during monitoring, the blood glucose is going to come down, your acidosis is going to come down, and later your ketones are going to come down. So blood ketones are very important in monitoring. So we have to do the blood ketones in these patients, at least initially 4th hourly, then 8th hourly, it's mandatory to do this. So by monitoring this, I think we can prevent the major complications, mortality from cerebral edema and hypokalemia, which are the most important things. And we can also rule out the other complications.
Thank you so much, ma'am. And moving back to our case, after 4 hours, we found that the blood sugar still remained high of 650 milligram per deciliter, and also acidosis was persistent with a base excess of 22. So what do you think went wrong with the management here, Dr. Prema?
Okay, as I told, like we are supposed to monitor any of these children with DKA in the PICU. Here I'm looking at the blood sugar, which is still very high, which should have come down within quite quickly, and the acidosis also is almost is worsening. So probably we have to look into whether we have given the proper treatment. So whether the insulin has been diluted properly. So most of the time what we do is we instruct the sisters, and she might have not diluted the insulin properly. So whether the insulin has been given appropriately, so we give 50 units in 50 ml. So whether they have diluted it appropriately, or whether it is insulin the tubings have not been flushed. And also we have to see if the child has other complications like infection and shock. So in these cases, we will not be able to correct our DKA as quickly as we are anticipating. So I think in this, the pediatric PICU protocol we usually do at our centers, we do this vitals and then Frischmann type of monitoring the cases for all the emergency cases where you look into fluids, your F for fluids, and then R for respirations, I for injections, insulin or antibiotics, whatever injections you're giving. Then C is for cardiovascular system, H is for hematologic, M is for metabolic, A is for abdomen, and N is for neurologic system. So like that, if you just go through this pattern, we will not be missing, and we have to look into if they have left any of our management. Is there any fault in our own management of these cases? So I think if that is there, if it is corrected, we can achieve a better control in these children.
Yes, ma'am. And the flushing was not done properly, and it was done later, which the sugars improved after 8 hours, where the sugars came down to 190 milligram per deciliter, and acidosis also improved with the base axis falling down to 12. And now, how do we have to proceed in this case, Dr. Vikas?
If you look at the progress of this child after the admission of 8 hours, the sugars are 190, and still child is acidotic. Now, this is a tricky situation, as we have keep on discussing the thing. Adequate hydration will lead to correction of hyperglycemia much before the acidosis. So your sugar will go down if you are addressing the issue of hydration very well. Even before insulin, your sugar will go down, and your acidosis will correct later on. But here, if you discontinue the insulin, you will have a case where the acidosis is persisting. So you are supposed to continue the insulin, and you have to add the dextrose to avoid another complication, that is the hypoglycemia. So whenever you are managing a child of DKA, always have dextrose and mannitol at bedside. It should be handy with you. Without dextrose and mannitol, do not manage a child with DKA. Always add dextrose if your sugar is falling without discontinuation of the insulin, because if you discontinue the insulin, you are going to have a persistent acidosis and a problematic child. So continue with the insulin infusion, and if you have got your glucose more than 300, no need of doing anything. Between 200 to 300 milligram percent, add 5% dextrose, and 10% dextrose if sugars are less than 200 milligram percent. So addition of dextrose, and keeping handy with mannitol, reviewing your blood sugars, reviewing your pH, and continuation of the IV infusion of the insulin is the key message with this slide. Dr. Naveen?
Thank you, sir. Thank you for the wonderful explanation. And 10 hours later, his blood sugar slightly increased to 220 milligram per deciliter, and the base excess was on the same range of 11, and his potassium found to be fallen to 2.6. So what do you think went wrong, Dr. Hema?
In this case, I would like to check that whether potassium was added in the hydration fluid or not, first thing. And second thing, if it is added, then this potassium level is truly low. So first thing I would do in this case would to reduce insulin by half, and if it is less than 2.5, I would rather give potassium correction. I would check for the ECG changes. If it is there, then we must correct it immediately and stop the insulin.
Okay, sir. Okay, thank you, sir. And after 14 hours, the child went into coma. So what could have happened to this child, Dr. Vijay?
This child now had an improvement and then became worse. So this, of course, is something which we already talked about, a very serious condition. You have to think of a possibility of a cerebral edema. So what were the risk factors? He was severe, rapid fluctuation. Now, the key message here, which already has been discussed a lot with regards to the previous discussion, is that we should not wait for imaging. Do not give, we should immediately rush with mannitol. So cerebral edema is a common condition which we encounter, and this is Neha's paper which we were discussing. Most of presentation in our center were actually at the time of admission. And after that, we had very few. So it is something which can be prevented if we do a good management, but you should be aware that it can happen at diagnosis. The major risk factors, as I said, included three things: outside treatment, which was the biggest odds ratio, and the other was new onset versus follow-up. So new onset, because they were presenting late, had a higher chance of cerebral edema happening. And the key messages are that if you have severe metabolic acidosis, pH less than 6.9, CO2 less than 10, prior treatment, think of cerebral edema, and that becomes very, very important from that perspective.
So 20 hours later, the blood sugar were in range of 190, and we found that the acidosis was still persistent. The base axis remained to be 12, despite giving insulin and treating the blood sugar levels. So what could we have? What could be the cause of this persistent acidosis, Dr. Prema?
Well, I think the blood sugar has come down very well, and thinking that in terms of we have given the right treatment as the sugars are coming down, but why we are having a acidosis still persistent. To think in those terms, we should think of the complications, as we were seeing, like cerebral edema is one of the complications. So the other complications, as we are giving a lot of fluids in this patient, we should also think about the chloride load. Suppose if it is other causes like lactic acidosis or excess chloride in this patient. So if we are going to look into, next is the ketones. So if the ketones, how much was the ketones in this child? So if it was ketones are more, then we should.
It was 1.4.
1.4. So suppose if it was ketones were more, that means we are not still appropriately treating our DKA. We will go in those terms. But if the ketones are less, that means our management of DKA is fine, but there is some other complication. So we should look into the chloride level. So if the chloride level is about 32, then we should think of a hyperchloremic acidosis. If it is less, then we should think of lactic acidosis. So we should look into the chloride load only to change the fluid we can think about in case if there is a hyperchloremic acidosis. So this is important message that if the patient persists to have acidosis, then we should think of other causes of acidosis rather than only ketoacidosis.
So thank you, ma'am. And after 28 hours, his blood sugar stabilized, which went to 170 milligram per deciliter, and his acidosis also improved with a base axis of 4, and he also regained consciousness, and he was taking on fluids and was allowed orally, and he was started with regular insulin of 0.3 unit per kg subcutaneously, and its fluid and insulin were stopped. So how do you taper the insulin, and how do you shift the patient to subcutaneous insulin, Dr. Hemang? And we also found that the sugar after 2 hours were found to be very high with 560 milligram per deciliter. So what could have went wrong? So how do you actually shift the patient from IV insulin to subcutaneous, and what are the precautions necessary to be taken before the transition?
Whenever there is a resolution of acidosis and ketosis and child is conscious and now ready to accept orally, we are planning to shift the child on subcutaneous insulin. So I will allow the child to take orally, and as soon as he had meal, I will stop fluid, but I will not stop insulin. Just before meal, I will give definitely subcutaneous insulin, but I will keep insulin drip for half an hour to 1 hour continue, so that there will be a good overlap between the subcutaneous insulin and insulin infusion, and it will not result in the hyperglycemia laterwards. So,
thank you. And we need to continue insulin, as you actually mentioned, and the patient was started on subcutaneous appropriately after then. And post DKA, he was actually managed on a sliding scale of 2 units per kg per day, and his sugars were extremely fluctuating. So, what could be the cause of extremely fluctuating sugars, Dr. Vikas?
Thank you, Dr. Naveen. Basically, what went wrong with this child is that this child is post DKA, so the requirement is very high, and often sliding scales are not very helpful. We have to shift the patient from on basal bolus regime, and you have to give the basal insulin around 12 hours before starting your subcutaneous insulin. So if you overlap and give coverage of a basal insulin around one night before the stopping of IV infusion, this will help to maintain the sugars in a reasonable range. Secondly, to start with the subcutaneous insulin, try to have a basal bolus regime rather than a sliding scale insulin. And as the requirement is high, it can be as high as 2.5 units per kg from 2 units per kg. So this will take care of fluctuating sugars. Always load with the basal insulin prior to a stoppage of your subcutaneous insulin. And secondly, whenever you are calculating basal bolus regime, always try to give at least 40 to 50% in terms of basal insulins, which should be started around one night before switching over the basal bolus regime as compared to the insulin infusion. This is very, very important. Secondly, whenever you are planning the discharge, I would like to add around 1 or 2 things, which is very, very important. Always try to explore what was the reason for DKA in this child. Whether sick days management has been given, I'm going a bit extra, whether sick days management has been given or not, because I've been seeing that sick days management has not been discussed in many of the endocrine clinics. Always try to spend 1 minute about the sick days management of a child. If you see whether the child was on pump, so talk about the pump malfunction, try to find out what lead to this episode of DKA. This will help in a long way to prevent further episode and recurrent admissions of the child with DKA. This is very, very important to explore the factor which will lead to DKA, and sick day management protocol should be discussed with before discharge. Am I right, Dr. Vajpayee? Agree with me?
Absolutely perfect. And that was a wonderful conclusion to this wonderful session. Just a quick word about the overview in terms of DKA management. When we are managing a child with DKA, we are walking a tightrope. We have an option of doing too much. We can give less fluid. We will cause dehydration. If we give more, we will cause cerebral edema. If we give too little insulin, we will wait for a few more hours. If we give too much insulin, we may cause death because of hypokalemia. Now, everybody will agree that it is always better to do little, causing less complications, even if there is more time. We should not go ahead with too much fluid, too much insulin, because that can cause a lot of problem and it can actually be fatal.